Welcome, fellow surgeons and colleagues from around the world, to today's webinar on the use of CardioCel 3D Bioscaffold. My name is Barnaby Rocha. I'm the surgeon at the Hong Kong Children's Hospital. We have been an early adapter of the CardioCel technology for congenital heart surgery for a few good years, and with good success as testament by thousands of successful implants worldwide since its introduction. We are very grateful to have Lemaitre, our sponsor today, to make this webinar possible today. And it is my privilege to introduce our speaker today, Professor Christian Brizard. I'm sure we are all very familiar with Professor Brizard's immense contribution to the community of pediatric cardiac surgery. He has been the director of the cardiac surgery at Royal Children's Hospital since 1999, and within his reign, the center has remained to be one of the best, most prolific, and excellent heart center in the world, both academically and clinically. Professor Brizard has played a crucial role in the development of CardioCel as a contender for a good, perfect material for congenital heart procedures. And without further ado, I would like to invite Christian to give us a talk. There will be plenty of time for Q&A after the talk, and please do leave your questions on the Q&A button on the right side of the screen. Thank you. Christian, please. Thank you.
Good afternoon, good morning, good afternoon in Australia, good morning everywhere in Europe, good night in America. I don't know if there are any Americans over there. I will go straight to the presentation. You have to let me know if all this works. Okay, so can you see my first slide?
Yes, loud and clear, we can see it.
Okay, I speak about the CardioCel 3D, which is the last product of CardioCel in the field of pediatric cardiac surgery. My name is Christian Brizard. I have been on the advisory board of Adventis Australia. Adventis is the new name of Admedus since 2007. Well, I've been working with Leon Needling since 2007, and I've been involved in the development of CardioCel, CardioCel Neo, and then CardioCel 3D. So before being a patch, CardioCel is a bioengineering treatment called ADAPT. It is designed to minimize the potential for calcification of the tissue while ensuring cross-linking of the collagen fibers. So I will dwell on three aspects of the treatment. First is a complete decellularization and removal of all cellular remnants. DNA remains, membranes remains, and that will remove all the parts of nucleic acid, the alpha-gal epitopes. Alpha-gal epitopes are the species antigens. So here you have sorry, I should show the pointer. Here you have the treatment, ADAPT treatment, that show absolutely no remnant. And here you have on a regular glutaldehyde treated tissue, lots of DNA residual. The second part that is extremely important is the utilization of monomeric glutaldehyde instead of polymeric glutaldehyde in all the other products. This is a single molecule of glutaldehyde with the two radicals, aldehyde radicals here. And a polymeric glutaldehyde is made of that same molecule, but replicated many times, several hundred times. So these molecules in a polymeric glutaldehyde molecule are linked through the drop of the oxygen here. And that linkage is relatively unstable. So the linkage between the collagen fibers and a molecule of glutaldehyde is made between the aldehyde radical here and the amynyl radical there, with the drop of one molecule of water. That bivalent link is extremely strong and very stable. So you understand then when there is between two collagen fibers and only one molecule of glutaldehyde, that linkage is extremely strong and will not break away. Whereas in a polymeric glutaldehyde molecule, you have between that link and that one, you have several hundreds of molecules of glutaldehyde that will continuously break away, remodel, create new links, and discover a new site for the fixation of the calcium. The last aspect is the removal of all residual glutaldehyde, and the CardioCel has zero residual glutaldehyde as opposed to significant level in other products. This is translated into the animal results, animal models. It is a subcutaneous implantation of either a bovine glutaldehyde treated at 0.625 with that buffer. This is what used to be our de facto or most common patch at the Children's Hospital in Melbourne, sorry, which was a human pericardium cryopreserved and treated intraoperatively with glutaldehyde. You can see that there is a drop of about 10 folds between the bovine control and our default patch. But then this is, for the sake of the experiment, the human pericardium cryopreserved has been treated with ADAPT. You can see a very significant drop of the level of calcification after 16 weeks. And here with ADAPT, virtually nothing. So we have designed a model, a valvular model. Here you have only the Pomwe valve. This is after 7 months of implantation in a sheep, juvenile sheep. We also implanted in the same animal on the posterior mitral valve. You can see that the patch of CardioCel is almost as new. And the functional aspect on echocardiographic study was extremely good. The histology would demonstrate in the autologous pericardium. You have to remember that the neonate or the very young sheep, the pericardium is extremely thin. Sorry. So what you have is a very thin patch that has been treated by glutaldehyde, and a scar process which is relatively significant. Instead of the CardioCel, at that time it was the CardioCel, the classic one, so 0.5 millimeter thick, with a very orderly and very controlled scarring process on both the atrial and the ventricular aspect. The picroserous red coloring or reaction allows to color in a different shades of red or orange the different molecule of collagen. Here in the CardioCel, you can see the patch and very orderly collagen 1 reaction or scar process. Whereas here it is all mixed and probably all collagen 3. So in summary, the CardioCel it is a bioengineered pure collagen matrix of bovine origin. It is completely cross-linked, has no residual glutaldehyde, no cellular remnants, and no alpha-gal antigens. It is declined into CardioCel Neo, which is 0.3 millimeter thick, and CardioCel 3D. At the Children's Hospital, we in neonatal arch and very young infants, we don't in biventricular repair, we very rarely use a patch, but we use that proximal end-to-side anastomosis, which allows to bypass the hypoplastic arch and have an unobstructed pathway to the descending aorta. But we are, this is how we do at the Children's Hospital. On the other hand, in patients with univentricular heart, the Damus anastomosis is very bulky and will create between the, if you do that proximal anastomosis, it will create a very narrow wedge between the descending aorta and the Damus. So in that setup, you have to augment the aortic arch with a patch. But most of the team outside of our unit would also use a patch in biventricular repair. So this is a study that we have done when we used to do the CardioCel in repair of aortic arch, but that was the CardioCel, the flat patch, and not the CardioCel Neo. So the CardioCel was 0.5 to 0.8 millimeter thick, and the patch was used to reconstruct the aortic arch. This is a pair study, so every patient with a CardioCel is paired with roughly 2 patients or 3 patients in our control group. The mortality is identical. The freedom from reobstruction is not significantly different, and the freedom from reintervention is slightly superior with the CardioCel. Again, it is a CardioCel, the flat patch, and it is, but it is not significant. What we see when we review the patients that have received a flat patch in the aortic arch is that construction with the flat patch is quite difficult. And you have the patch that is absolutely intact, that has not thickened, but you have a neo-adventitio that created by the turbulences generated by the fold. You can see that the patch is multiply folded there and there as well. So these turbulences are generated by the fold in the patch, and they occur at the level of the, this neo-adventitio occurs at the level of the native aorta and the patch, so it's not exclusively on the patch. So the CardioCel 3D, what is the rationale to design the CardioCel 3D? Because as you imagine, and what if you have used the CardioCel flat to reconstruct small neonatal arch, you can tell that it is very difficult to achieve a curvature in the all 3 planes. You can do a half pipe, so you have a curvature in 1 plane, but a curvature in 3 planes is impossible to design with a product that is not completely elastic as a homograft wall would be. So the angle of this, if you take the axis here and the axis there, the angle is 60 degrees. The length of the patch is 6 centimeter, and the width from one edge to the other is 4 centimeter. What is the rationale for using the CardioCel in a Norwood procedure? So the CardioCel 3D would have a predictable size. You have a predictable compliance. The shape is known to the operator, and the radius of curvature is fixed. it has complete decellularization, so it is not leading to immunological buildup or memory once the patch is implantation, as opposed to the homograft. You can get it off the shelf, of course. The cost compared to the pulmonary homograft wall is very competitive. And it is important to realize that the other material, especially the pulmonary homograft wall, is not exactly satisfactory. Yes, it is easy to handle, and it is most of the time relatively hemostatic, so it is pleasing for the surgeon on that point of view. But if you analyze the shape of the aortic arch reconstruction, as it has been done here in this Japanese paper in 2012, you have 6 patients. You have only 2 that are represented. This is the surgery that was done. This is a graph of the surgery, and this is a 3D reconstructed model obtained with CT scan after the BCPS. So one at 26 months, here at 15 months. And so these 3D reconstruction model have been animated with turbulent and pulsatile flow situation. So here you have the streamlines of the at the peak systolic phase, and you see that the turbulences are generated every time there is a change or an abrupt change of caliber. And so here you have a very acute angle and a change of caliber that is spectacular. Whereas here you have a better shape, but the change of caliber is quite abrupt as well. The wall shear stress is represented in green and red. Here you have very low shear stress, but very large diameter and lower shear stress. Whereas as at the recoartation, or what we should say, it is extremely high. Here the pressure distribution across the wall, and as the radius of this ascending aorta is extremely great, the pressure distribution is very high. So these angiograms, you look carefully at the shape of the ascending aorta. These angiograms are taken in the single ventricle reconstructed trial, the paper by Rick Oye in 2012 or 2010. So these patients have been followed and have led to multiple papers afterwards. But before the BCPS, 360 survivors have their angiogram shown in that video. And you can see the range of shape that is absolutely sometimes grotesque that is achieved with the pulmonary homograft tissue. The technique we use at the Children's Hospital is it's been the same for the last 20 years. So we do an excision of the coarctation and at some stage and transect the ascending aorta. At some stage, the aortic arch is completely isolated from the descending aorta and the ascending aorta. And then once the isthmus has been resected, the posterior wall is reconstructed, and we use a patch of CardioCel 3D, and that patch is eventually cut back and to allow for the about 12 millimeter diameter, or between 10 and 12 millimeter diameter of the aortic root containing the little ascending aorta there. And this is our setup. This is one image once a patch has been implanted before it is cut back. In this video, you can see what is important It should say, sorry. It was playing about 2 minutes ago. No, I cannot manage to have it play. You have the aortic arch is here, and then you have the descending aorta is there. There is a perpendicular cut back to enlarge the superior aspect of the descending aorta. And then what is very important, and you should see it on the video, I'm very frustrated that it does not work. You should see it that we take great care to measure the amount of tissue available at the posterior aspect of the arch, the amount of tissue available at the anterior aspect of the arch. Here we want to achieve between 7 and 8 millimeter. And so that amount of tissue available will be subtracted from the circumference of an 8 millimeter probe, whereas at the anterior aspect of the arch, it will be subtracted against a 10 or 12 millimeter probe. And that creates, allow this together with the length of the patch between the posterior suture line and the anterior suture line, that allows to cut very precisely the patch. I think you'll be able to see it in another slide. So this is the kind of reconstruction we achieve with our technique. This is the MRI that we take at 3 months before the BCPS. You can see the reconstruction here on the MRI, and this is the animated model. Okay. Now, this does not move on us. And do some maneuvers to reload.
Saw that working before the call started, so hopefully you can get it.
So it should work now. Yeah, it is working now. So that here you can see that we calculated the length of the aortic arch. So that will be the length of the patch. And here we calculate the amount of tissue available at the posterior aspect and the amount of tissue available at the anterior aspect of the arch. This is how we design a patch on the. So because the patch is curved, it's very difficult to have a nice image of the midline. So you have to design the midline to be sure where you are. So the midline is designed there. This is the length of the patch that will be required. Here we have cut the template that is required for to create a 7 millimeter diameter at the posterior aspect. Here it is a 12 millimeter at the anterior aspect of the patch. This is a patch once it's been cut. There it is in place, and then we cut back to allow for the implantation of the damus. Okay, so I am a bit relieved that I can show you these images moving, that you have seen that. So there are most of the surgeons would use the classical Norwood reconstruction, and so this is here in purple and in pink you have the native anatomy of a hypoplastic heart, native anatomy. And then in red, you have the ideal arch reconstruction. This is the arch reconstruction, ideal. This is a work that I did at Great Ormond Street last year. And this is the shape of the patch that you want to achieve. So you can achieve this with a CardioCel 3D. I find it more difficult, but this can be achieved. But you have to remember that beside the shape, you really need to have a reconstruction that is completely avoid all the folds. So if you have a very complex shape to achieve like this one, you need to be sure that there are no folds. But this is, so here you have the neo-aortic root, the pulmonary root, and this is a patch with the small amount of native tissue, and the patch is more deployed to the left of the aortic arch. Okay, so the aortic arch reconstruction in neonates, infants, and young children, we use the CardioCel 3D when we cannot do an extended proximal N2 side. So what is very important is the way the patch is cut and the way it is extending into the ascending aorta. So resection of the coarctation, reconstruction of the posterior wall, the dimension and the width of the patch at the posterior aspect is carefully calculated according to the amount of remaining tissue. And then the patch will augment the aortic arch, and you have to calculate what will be the width of your patch very carefully. But the proximal part on the ascending aorta, you need to finish it in a very pointy way, and the construction is quite careful. This is a posterior view. This is a posterior aspect of the ascending aorta, and you see that the patch is finishing in a very pointy way. So this is a 9-year-old boy with a coarctation and mild hypoplasia of the aortic arch, transverse arch distal -3, proximal -2.2. Our threshold for arch reconstruction is very low at the Children's Hospital. We're probably -1, and we would do a reconstruction of the. So you have a picture of one patch implanted. Sorry, this was a movie, so I have to get out. I have found out that when you have the laser pointer, it does not work. So this is the final part of the coarctation reconstruction. The isthmus and the coarctation has been resected. So you have tissue-to-tissue anastomosis. Then there's a clamp distally, and the aortic arch is pressurized, and you measure very carefully the amount of tissue available at the size of the aortic arch between the left carotid artery and the innominate artery. And so you use these templates, and the patch is cut according to the template along the radius of curvature. Then we have an isolated perfusion of the right innominate artery, and the inner curvature is cut back. Again, there is a vertical incision in the descending aorta, and the patch is sutured in place. Then the arch is de-aired, it's circulated. And that is the aspect. All right. So other example of the same process. Other patients, so you can see the patch there. The picture is not as good. So our results, we have had 48 implantations at the Royal Children's Hospital since May 2017. In 38 neonates.
Code grade North Building, level 4, cockatoo, room 438. Code grade North Building, level 4, cockatoo, room 438.
So in 38 neonates, we have used 41 patches, 38 immediate good anatomical results. There were 8 deaths, of whom 5 were early in the first months of life. There is 3 reinterventions related to technical mistakes. So in 2 patients, there were holes in the patch, and in 1 patient, there was inadequate initial sizing. So these patches have been replaced with CardioCel patches as well, 3D patches. In infants, 1 patient or 6 young children, less than 6-year-old, we had 7 good results. This is a typical echo study which shows low velocity in the reconstructed aortic arch. Thank you very much for your attention. Okay.
Thank you, Professor Prasad.
Thank you.
So if anyone have any questions, please do post it on the Q&A button on the right side. Thank you, Christian, for a great presentation. Very, very impressive results and very clear instructions on how to reconstruct the arch. May I ask a few questions to start off with? For the 40 patients in your cohort, were there any re-intervention in the survivors that you just mentioned?
The patient, so there are 3 re-interventions. Our re-intervention afterwards? No.
Yes, or no. Catheter-based.
No, we don't do a lot of catheter intervention, but there was no re-intervention at the time of BCPS. We have a lot of re-intervention on the pulmonary artery, but not on the arch.
Would you recommend the 3D patch on other vascular reconstruction, for example, the pulmonary arteries? Or I know the curvature is made for the arch, but
certainly we recommend the CardioCel Neo for small patches in small infants on the pulmonary arteries. In neonates, I'm not sure yet what is the best material. Some would like to use the CardioCel Neo. I don't think that the CardioCel 3D is necessary. Certainly when we do unifocalization, we use small patches of pulmonary homograph wall in the distal PAs and the markers.
So we have a few questions coming in. Dr. Siva from Malaysia is asking, in the case of aortic interruption, how would you tailor the 3D patch for arch reconstruction?
I don't have the experience because in interrupted arch, we use a proximal end-to-side anastomosis.
Okay.
But if I were to, I would be very careful to not to augment the diameter of the proximal arch too large. You have to be careful to tailor your patch to have a size of the aortic arch that is no greater than 5 or 6 millimeter at the most. 5 millimeter in neonates is what you want. So then you would augment the proximal part of the arch with the CardioCel Neo, and then you do a end-to-end anastomosis left subclavian artery, or distal to the left carotid artery if you have a type B.
Just to follow up on that question, so we saw the older child with the arch reconstruction you did. So of course the anticipated diameter would be different. So you would use a program of sorts, or a table for the normal C-score of the descending aorta size, or?
Well, normally I use a 7 millimeter probe as the smallest one. If the patient is a bit large, 3.5, 4 kilograms, then you use an 8 millimeter probe. But I very rarely use smaller. If you have a very small patient, you can use a 6, like a 2 kilogram baby, and use a 6. But most of the time it's a 7 millimeter probe for the distal arch. I'm quite careful to measure the diameter of the pulmonary root to match the size of the pulmonary root. In general, what we try now is to have as much an anterior anastomosis, or plugging of the damus into the aortic arch. We try to do that as anteriorly as possible to try to avoid any compression of the left PA.
We have a question from Dr. Lionel de Sherry. So he's asking, what would you recommend the first use of the CardioCel 3D patch? And do you have like 3 points of vigilance and mistakes to avoid?
The first patient to use the CardioCel, I would 3D patch. The first patient to use the CardioCel 3D would be an hypoplastic aortic arch in a child that is older than 6 months, where you don't want to do an extensive dissection of the descending aorta, or an older patient. And what I have outlined in that video is that you have to take really very careful measurement and try not to oversize. You really want to have a harmonious arch and not a disharmonious, almost aneurysmal that you can see if you oversize your patch.
So does it matter if you take it off the middle of the patch or towards one side of the patch? Because the arch shape is equal on all sides, yes?
Yeah. It's an even curvature all around. The patch is made so there is, as opposed to the CardioCel flat patch. The CardioCel flat patch is cross-linked without tension. And to achieve the curvature and the shape, you have to apply some tension on the pericardium on a mold. So there is the CardioCel 3D is fixed under tension. So that that gives slightly different properties of the pericardium, of the CardioCel, because it is stretched when it is fixed.
We have a new question from David Lucken. It says the average age of the patient is 9 or 10. I think it was referring to the older child that you had on demonstration.
Oh, that was one patient that is 9-year-old.
He was asking why he can survive with such a narrow arch. I guess it's not very narrow.
It's not that narrowed. It is so the proximal Z value is -2. Some teams would consider that borderline for intervention.
Well,
so it's not that small.
So knowing that the construction of the crosslink of this patch is different from the flat patch, would you use the remnant tissue from the 3D CardioCel to do other repairs intracardiacally, like a VSD or anything else?
I would love to, but you have to fight with your scrub nurse who would
throw away.
No, it is. In theory, it is possible, but you can use it to close a VSD in the same patient. Yeah.
Are there any new questions? Okay, so we have a question from Lucy Naraido, who's a salesperson here and engaging with the surgeon. And he's asking how she can encourage the use of CardioCel for the first time and to get them to make the leap of faith from a different patch. So this is a salesperson asking how you would sell to a surgeon to make a leap from another patch material.
I think if you do an aortic arch reconstruction in an infant or a young child, it's much better much easier to use because the shape is there already than a pulmonary homograft wall. It is much better than using the corrugated Dacron, which is very stiff, and you can do mistakes in the calculation of the length of it. Because in general, when you use a patch, you have to match the compliance of the tissue of the host and the patch. So if you any other material than the CardioCel or the pulmonary homograft would be stiffer than an infant or a young child aortic arch tissue.
Just a follow up on that arch reconstruction. What would be the oldest children you would use this patch on? Because there's a limitation on the size of this 3D patch. And, in older children, we tend to use more adult graft material. I think
if you have a nearly grown-up child or a child that is post-puberty, you can use all the adult material.
So we have another question from Sifa. So he had a case of double inlet left ventricle with AP relationship of the great vessels, and he had to do a Norwood on this. So I guess the Damas would be a different configuration. So he's asking if this 3D bioscaffold can be used for arch reconstruction in this case, where there's an AP relationship.
Yeah, absolutely.
And he's asking how you would tailor it differently. So it will be tailored at the spot definitely. And
you have to your Damas anastomosis. Normally, you have to tailor the Damas anastomosis so that it is non-obstructive on either side. What I normally do is that you join the pulmonary root, which is the largest, with the aortic root using 1/3 of the diameter of 1/3 of the circumference of the aortic root. Normally, I scallop a little bit so that there's a big orifice. So I scallop both when they face to face there. And then the combined orifice is about 10-12 millimeter in a neonate. So your proximal arch will have to adjust to match that diameter. You don't want to have to narrow your anastomosis to match a too small a diameter of the anterior aspect of your reconstructed arch. So the arch tapers, as I showed in the patch in the Norwood patient.
Dr. Indy Baku was asking, have you, in a redo surgery, have you seen an implanted CardioCel patch after a significant amount of time, and how do they look?
We haven't got a reoperation for at the long. We have early reoperation. We have had reoperation, and there was because I received all the adverse event, or I used to receive all the adverse event in the neonatal arch reconstructed with the CardioCel, the regular CardioCel, the flat patch, but the thick one. There was a not significant, but a certain number of patients that have had the buildup of a neoentima, and that neoentima has been the cause of re-intervention at some stage. And this neoentima is not very adherent to the patch itself. So it can be, if you're bold, you can detach the neoentima, but you have to make sure that there is no folds in your patch. So it's better to redo. But that is with the flat patch. I haven't seen reports of neoentima with the CardioCel 3D. I think because it is much easier to reconstruct a complex structure with the CardioCel 3D than with the flat patch.
Yeah, I think we have 2 more questions and we will end the session. So Dr. Melkasik is asking, he's commenting that the 3D shape has a big advantage, but has the no calcification aspect of the material has much impact on your decision on choosing this patch? So he's
not really, because the patch is in the arch or into it's like in a VSD, or it does not move very much. But eventually, if that would calcify, you would have a very rigid patch. Whereas here, the patch still retains some elasticity, and so that part of the compliance and the ventricular aortic coupling and all that. So it is better. It is not very important that it does not calcify in the long term, but it is better if it didn't. On the other hand, the CardioCel for the flat patch, especially the CardioCel Neo in infants, for the valvular reconstruction, it is absolutely essential that the characteristic that it does not calcify is absolutely essential. So there are some teams that report calcification, but you often it is associated with endocarditis, and you can have a calcification at the site of the suture line, because the proline generates calcification.
Mm-hmm. A question by Siva again about redo arch reconstruction. So if a patient had a previous arch reconstruction coming back older with a redo surgery, would the 3D patch be a good option for a bigger patient?
Absolutely.
Okay.
I think it would be the best option, providing that the child is not an adult and you have alternative options that are that are easier to handle. The CardioCel has been tested at about the rupture threshold is greater than 10 times adult systolic pressure. So there is a margin. So you can normally use it with any size, but then you need to, in adult patient, you would need to use larger needles, and then you have needle holes.
Dr. Napoleon is asking about histological evaluation when these patches were explanted. So,
expanded.
Yes. So that, as you were mentioning, I remember there were some calcification, but not a lot, right?
Explanted.
Yes, explanted.
There's no, in general, there is no calcification in the patch that are explanted. You can find some very rare reports of calcification when there is associated infection on the carditis, but otherwise we don't have records of calcifications. And there are in the animal models, and you can have calcification at the site of the suture line.
Yeah, I think that's all for the questions. Thank you so much again for the time and the great presentation. I think a lot of us are very convinced about this patch. I've used it personally and find it really nice handling, and makes the operation much easier process. And especially for regions like us where we don't have homograft to supply, it is a blessing.
But the pulmonary homograft is easy and nice to work with, but it is very unpredictable in the way it develops, it dilates, and so it is quite. It's a false friend. It really not as good for the patient.
Yeah, I think we all agree. If there's thank you so much again for the time and for everyone for coming in and for Lamette to organize this, and hopefully we have another chance to speak again in the near future. Thank you so much, and we end the session. Thank you.
Thank you, Barnaby. Very nice to see you.
Yeah.
And thank you all.